if there's a problem with the nerve supply to the gut, then that can lead to bowel dysfunction arising from this brain-gut axis dysfunction.
IBS, Irritable Bowel Syndrome, includes digestive symptoms. Pain, altered bowel function, this can be constipation, diarrhea, or an oscillation between the two, bloating or distension, and perhaps also flatulence. One of the things that we can start with is kind of how we define IBS, because this has shifted a little bit. And I think this is an important point to make, which now the definition is more favoring the gut-brain axis or gut-brain interactions. So do you maybe want to tell us a little bit about how the thinking and the diagnosis of IBS has been updated?
Yeah, that's a great place to start. So I guess we've moved away from the concept of IBS as being a functional gastrointestinal disorder over the last 7 or 8 years, partly because the term functional sort of questions the legitimacy of IBS as a diagnosis, and therefore that sort of leads to stigma for people who suffer from IBS. There's been increasing evidence over the last 20 years or so that IBS can arise as a result of dysfunction in the gut-brain axis. So the brain controls the function of the gut and it controls sensation and motility and things like that. So if there's a problem with the nerve supply to the gut, then that can lead to bowel dysfunction arising from this brain-gut axis dysfunction.
2023 review paper from the journal Gastroenterology, quoting approximately 4 out of every 10 U.S. adults has DGBI, disordered gut-brain interaction. So it's well established that this is not an uncommon phenomena, and it's actually this DGBI, it's the new name for irritable bowel syndrome because the neurological or the brain-based component is so important. When the low FODMAP diet was compared to normal IBS diet advice, the low FODMAP diet was actually the best for abdominal pain, bloating, and modulating or correcting bowel regularity. So if people had diarrhea, it helps make them less diarrheal. And if they have constipation, it helps make them more regular. The next study I wanted to share with you, it was a clinical trial, albeit small, 8 patients who had GERD, gastroesophageal reflux disease, and IBS. But here's what's interesting. They were given either a high FODMAP or a low FODMAP diet. They found that the high FODMAP diet led to worse reflux. Foods that are high in FODMAPs are certain fruits and vegetables that are rich in prebiotics that feed bacteria. Probiotics are the bacteria, prebiotics feed the bacteria. And so the low FODMAP diet that restricted prebiotics and therefore didn't feed bacteria had improvements in reflux. So what does this tell us? Well, firstly, that a diet that is mindful of if someone has bacterial overgrowth is important to keep in mind when people have things like reflux. And by the way, if this has been helpful, please comment and subscribe. This really does help us reach more people who are trying to improve their health, so it is quite deeply appreciated. Let's come to some of the tips for implementation. Here is a quick snapshot of some of the more common foods people consume, whether they are low FODMAP or high FODMAP. And really quick, we do have 3 different versions of this diet, not to confuse you, but because some people will do just low FODMAP. Some people are looking to combine low FODMAP along with a partial elimination as dictated by a paleo diet. So we have the standard low FODMAP, the paleo low FODMAP, and then some people are on a vegetarian diet. So we also have the vegetarian version of the low FODMAP diet, just to give you a handout that's going to be most tailored to your needs. When looking at grains, you can consume low FODMAP, which would be oats, quinoa, and brown rice, but you want to be avoiding the wheat, the rye, and the barley. Now, we've discussed before, not going too far afield, but I suspect that there's a subset of people who have gone gluten-free and they've cut out wheat, rye, and barley, high FODMAP, seen improvements, and incorrectly concluded that they're gluten intolerant. It's actually, at least seemingly so, more likely that people are FODMAP intolerant than they are gluten intolerant. Why this matters is FODMAP tolerance is very able to be recovered. Whereas if it's true immunogenic gluten gliadin reactivity, the proteins, that does not tend to be highly recoverable, again, where FODMAPs are. So just file that away because it would be unfortunate if you never performed a gluten retrial. So that's the grain piece. What I think also trips a lot of people up, and this kind of comes back to the worse I eat, the better I feel, is the vegetables. Some mainstay vegetables, mainly from the brassica family, are all high FODMAP. So things that you would want to avoid would be broccoli, cauliflower, asparagus, garlic, onions, and avocado. And just simply swap in for those kale, spinach, carrots, cucumbers, green beans, and zucchini. Fruits can also be problematic. The main ones here would be to avoid apples, grapes, plums, peaches, and watermelon, and then simply swap in berries like blueberries and raspberries and strawberries. And then dairy can also trip you up, as you would imagine, because dairy contains this carbohydrate that requires assimilation, lactose. Lactose-free milks, cheeses, and yogurts would be okay. And then most milk, other than things that are hard cheeses, you would want to avoid. Again, we have the more comprehensive food lists available for you. Let's come to the best way to implement. If we think about this in 3 phases, the first phase I like to call the test phase or the prove it phase. Try the diet. Do you improve? If so, great, keep going. If not, move on to something else. That's only 2 weeks. I would say 4 weeks max. If you're not clearly noticing improvement by the 4-week mark, this is either the not the right diet for you or you're missing something. Then you ride that wave, right? You're improving. Give yourself, again, if it does seem to be helping, give yourself 1 or 2 or so full months on the diet. And once you feel healthy, well, like you're a little bit more robust, your symptoms are kind of in the rearview mirror and you've been stable at least for a month. Now we start reintroducing, wherein you may notice 1 or 2 or 3 foods don't sit well, but you should see the majority of these foods be tolerable. So this also begs a question about how strict you should be when you're doing that prove it or that initial testing phase. Opinions here will vary. Here is the data-driven approach that comes from one of these studies. They looked at level of compliance, either all in, totally compliant, or they labeled it some, partially compliant. Those who were all in had an 89% improvement in their symptoms, whereas those who were sometimes low FODMAP had an 80% improvement in their symptoms. The difference in outcome between total adherence and partial adherence is minimal, is fairly nominal. And this is why we so often will say repeatedly at the clinic, when you're doing this diet, think about 80-ish% compliance. Don't spin your wheels or freak yourself out about if you're traveling, there's a wedding, a social event, whatever, you can have some indulgences. In fact, we look at that as an opportunity to test the waters and see how you do. Sometimes people will say, I'm actually more tolerant than I thought I would be. Yay. Or they get good reinforcement that, okay, these foods truly are triggers and I'm not quite ready to bring them back in yet. So the framing of this is really important. Don't make it a perfection or fail scenario. It's not the right way to frame this. And I did want to share just a data point or two about when you get to the reintroduction portion of the diet. This comes from a 2023 observational paper. Here are 2 quotes that I think are very encouraging. For every single food challenge, more participants reported a successful food challenge than reported a failed or a reaction to the foods they challenged. Great. One more quote, or continuing from. More than half of the foods challenged or reintroduced were tolerated by participants, indicating these foods can be included in the long term. So again, a very optimistic outlook for first, you establish it's helpful. Second, you give your body some time to heal. And then third, you reintroduce and find your way to food freedom. Now, there are some cases where people may notice, literally or seemingly so, everything they eat elicits a negative reaction. An option for these people, I'm not saying it's the only option, but a good option is an elemental diet. This is essentially a meal replacement, but with the important caveat that this has been formulated very specifically to have zero FODMAPs and to be very easy to digest and also simultaneously hypoallergenic. And what this is able to do is help to reset that bacterial overgrowth, the resultant inflammation, immune system signaling, and nervous system amplification. I think a practical way, a simpler way of using this is not to do what Mark Pimentel did, which was 2 weeks exclusively. My view is that's too high of a bar, but instead we can use it as a reset. 1 to 4 days in duration seems to be enough to quell symptoms and get most people moving. So you do it generally, mostly exclusively 1 to 4 days. And then from there, you can replace 1 or 2 meals per day. What's my evidence for that? A drove of clinical trials in inflammatory bowel disease showing reduced inflammation and reduced disease activity when using the elemental diet to replace roughly half of one's calories per day. How do we use probiotics to improve our health? In this case, looked at diarrhea. Randomized control trial. And the setup here was interesting. They took 200 people with IBSD, diarrheal type IBS. They gave them either placebo or Bifidobacterium longum at 1 billion CFU per day, so standard dose, or Bifidobacterium longum that was heat killed. And here's what they found. At 3 months, both the normal or living probiotic and, comparatively, the dead probiotics had a measurable, noticeable, and significant effect on improving diarrhea. And I want to call your attention to this graph. What they're doing here is known as I believe this is technically a Likert score. So they're essentially taking a symptom inventory questionnaire every roughly 30 days. And what you see is that even in the placebo group, there's a small improvement in symptoms, but there's a significantly higher level of improvement in the diarrhea in both the alive and the dead probiotic group. But look at this, I think, more key point, which is day 30, you see some improvement. There's more improvement at day 60 and even more improvement at roughly day 90. So, as we've covered with other research in the past, it does seem that a minimum of 2 or probably even more like 3 months is what you should utilize a probiotic protocol for so that you can obtain the full effect. One of the things that I really appreciate about probiotics is they tend to be corrective, meaning if you have diarrhea or constipation, probiotics bring you back to center. This doesn't happen with some therapies in the GI toolkit. Let's say you are constipated and you use magnesium, senna, vitamin C, prokinetics. Those will help with the constipation. However, if you have diarrhea and you take those, they will make your diarrhea worse, quite worse in some cases. Probiotics novel in the sense that they're corrective, and that's case in point with this next study, a meta-analysis that found probiotics were effective for constipation. 17 randomized controlled trials were summarized in this meta-analysis. There was a placebo group, always very important, and as you can imagine, with 17 trials being summarized, there was difference or some changes in the probiotic formulas that were used. So some were lactobacillus, some were bifidobacterium, some were soil-based, some were single formula, some were blends. It really didn't seem to matter. There was efficacy demonstrated across trials despite the formulas being different, which is why I've said for so long, we don't have to make probiotic use very complicated or super specific. Also, they added in some of these studies, along with the probiotic, they added a prebiotic. This is known as a synbiotic. So a probiotic is just the bacteria, A prebiotic is just the substrate that feeds the bacteria, think inulin or FOS. And then a synbiotic is a formula that gives you probiotic plus prebiotic. That's relevant because they found that either probiotics or separately to that, the synbiotic treatments, both of these were better than placebo in treating constipation. The synbiotics were more effective for constipation than just a probiotic, meaning a probiotic combined with a prebiotic is more effective for constipation. If constipation is your primary symptom, because some people will go to diarrhea and oscillate back to constipation, different than that would be someone whose predominant symptom is constipation. You might want to consider adding a prebiotic along with your probiotic. Now, there's also an important nuance here in that for people with bloating, pain, and diarrhea, prebiotics don't seem to offer any benefit. And this was summarized in a recent meta-analysis looking at IBS, remembering that IBS is a number of symptoms. Prebiotics did not demonstrate any efficacy for IBS. But in this study, when looking just at constipation, the combination of probiotics with prebiotics was better than probiotics alone. So again, if constipation is your primary symptom, you might want to consider adding to that a prebiotic. The way I would advise doing this, and always check these things with your healthcare provider, but as a general principle, because in some people, prebiotics can trigger bloating, pain, gas, I think it's best to quell symptoms with a probiotic alone first, like that last study demonstrated improvements in bloating and pain in the IBS score. So quell symptoms a bit first with a probiotic, using a probiotic in isolation for 1 or 2 months, then layer on top of that the prebiotic. Regarding dose, some studies have found that 5 grams of a prebiotic offers benefit with really a minimal likelihood of triggering flatulence, gas, bloating, and pain. You could go to 10 or even 15 grams per day. I would just take this in a stepwise fashion. First, probiotics, 1 or 2 months, get to a baseline. Then prebiotics, 5 grams per day. If that works wonderfully, great. No need to increase, but you could go up to 10, give that a couple weeks, and even up to 15. Probiotics have been shown to improve GERD, to reduce inflammation, to reduce leaky gut, to combat SIBO, H. pylori, and fungus, and also lower levels of histamine. Looking at a 2020 systematic review, 79% of the studies reviewed found that probiotics improved GERD. Quoting, in conclusion, probiotic use can be beneficial for GERD symptoms such as regurgitation and heartburn. What you see in the research here is most of the studies have examined the type of probiotic we call a blend of lactobacillus and bifidobacterium. This is kind of your traditional probiotic. For this type of probiotic, and on the label, you're going to be looking for predominantly lactobacillus and bifidobacterium, anywhere between usually 8 to 15 different species, at a dose of 1 to 50 billion per day. A little higher is fine, but that's the general dose range for about 2 months. Now, to have the strongest probiotic, our hypothesis is you want to combine the 3 formula types together so as to have, we call it the triple therapy probiotic. So you combine this with Saccharomyces either boulardii or cerevisiae, and you'll see the dosing here listed, but essentially 10 to 15 billion or 4 to 8 billion for 2 to 3 months. And then finally, a soil-based probiotic. This will have various bacillus species in the formula at a dose of 2 to 6 billion, again, for 2, maybe 3 months. Looking at curcumin in a clinical trial, they found that after 2 months of curcumin, 60% of people no longer had IBS. That's pretty remarkable for an inexpensive and very safe supplement. There are meta-analyses finding improvements in inflammatory bowel disease, in inflammatory markers, in joint pain, either in RA, rheumatoid arthritis, or osteoarthritis. and also small improvements on metabolic health like body weight, blood sugar, and cholesterol. There was also one study looking at, can curcumin function as an antimicrobial? Can it actively kill bad bacteria? We do have a meta-analysis, so that's an impressive data point, looking at Helicobacter pylori, or H. pylori, this bacteria that lives in the lining of the stomach mostly and can cause things like bloating and reflux and also ulcers. When combining curcumin with antibiotics, they found an increased clearance rate of H. pylori by 8%. So that's not a lot. It is something, but there does seem to be at least a modest antimicrobial impact that curcumin exerts. One of the best encapsulations of gastrointestinal symptoms, this sensitive gut, if you will, what we sometimes call a bacterial type gut. And in this trial, they compared omeprazole, aka Prilosec, against curcumin. And they found equivalency in the outcomes, which in my mind is absolutely amazing. So instead of using omeprazole and suppressing acid, which can have some deleterious benefits, I do think acid suppression in the short term is justifiable. Is it ideal? No. Is it justifiable? Yes. You have a different option of curcumin at a dose of 1 gram per day. And that has been shown, again, from this trial to be equivalent. This led the researchers to comment as follows, quote, curcumin and omeprazole had comparable efficacy for improving dyspepsia. So fantastic news. Growing evidence for natural medicines, in this case, curcumin and its efficacy for reflux. So then how to take curcumin regarding dose and form. I feel, and this is just essentially what you're seeing used across most of the trials, a dose of 500 milligrams per day up to 1,500 milligrams per day. Most curcumin is anywhere between 250 and 500 milligrams per capsule. One of the things that happens when inflammation is chronic is it can actually start to skew those deeper brain centers like the amygdala and hippocampus, the centers in the limbic system, to become more locked in this fight or flight swing of that pendulum and not allow the individual to swing back to parasympathetic rest and recover. So it's really important to state that foundational lifestyle practices are key here. Exercise, sleep, time in nature, also known as Shinrin Yoku or forest bathing, meditation, prayer, cold water exposure, music, dancing, laughter, singing. These things are all very important, and I would advise to do those as much as you can, of course. But there's a device for people who may be doing those things or may have a hard time doing those things. There's a device that can simplify and provide an additional level of stimulus to that parasympathetic part of the nervous system. This is known as auricular or ear vagal nerve stimulation. A headphone, a specialized headphone that creates a low-level electrical impulse, sort of a buzzing in your ear that stimulates the vagus nerve, and that's going to have a retraining effect on the amygdala and also all this downstream benefit that we want. Now, what really sort of swayed me here regarding the viability of this therapy was a 2024 clinical trial. They took 40 patients with IBS. Half of them were given a sham, meaning it looked like the treatment, but it actually wasn't. And the other half were given the actual auricular vagal nerve stimulation for 30 minutes once per day for 1 month. At the end of that 30 days, they demonstrated only in the group getting the treatment improved abdominal pain and bloating, a balancing of healthy bacteria levels, increased acetylcholine, like we discussed earlier, improved vagal tone, as you would expect because those two go hand in hand, improved bowel regularity, and reduced anxiety and depression. The device is called VaguStim, and there are other devices on the market. This one we found to be the most in keeping with what the majority of the research studies have used. And again, you can use this for about 30 minutes, 1 to 2 times per day. And this is going to have a gradual effect on retraining the nervous system not to be so sympathetic and allow you to be parasympathetic, rest, digest, acetylcholine, anti-inflammatory, pro-motility, a lot of good things when we get this balance right. No supplement for time in nature, sleep, meditation, but rather a complement to those factors. If this seems like a lot and you need some guidance, please reach out. Would be more than happy and honored to help you. Again, this really is at the center of what we do. And really, all of this is built upon, in part, my own suffering and then wanting to help alleviate that suffering of other people. So if you need help, reach out to the clinic and we will be more than happy to help. This is Dr. Ruscio, and I'll talk to you next time.